Good afternoon, everyone. This is Christine at CEHRT, and thank you for joining us for the prior year 2020 Stage 3 requirements. This presentation is provided through a shared commitment between Access, ADHS, CEHRT, and Myers & Stofert to increase participation in the Medicaid Promoting Interoperability PI program. A few logistical reminders. Today's webinar will be recorded and posted to the CEHRT and Access websites. Please use the chat box for questions or comments. Please include your name, practice, organization, and do not include any confidential information such as PHI. Again, all lines will be muted. Connie, are you with us?
I am, Christine. Thank you.
Thank you, Connie.
Today I have the honor of introducing our presenter. She is Priscilla Clark, as Senior Accountant with Myers & Stofert, a certified public accounting firm specializing in federal and state Medicare and Medicaid programs, is our webinar presenter today. Priscilla, you may begin your presentation.
Thank you, Connie. Thank you, everyone, for joining us. As previously stated, we will be discussing Program Year 2020 Stage 3 objectives for meaningful use. The learning objective today would be to understand the Stage 3 requirements for the Medicaid PI program. The second learning objective is to understand the differences between Program Year 2019 and Program Year 2020. The third objective is to learn about Program Year 2020 Stage 3 documentation requirements. Meaningful use, the HITECH Act description is the Recovery Act specifies the following three components of meaningful use. The use of certified electronic health record technology, the CERT, is used in a meaningful manner. The use of the CERT for electronic exchange of health information to improve quality of health care. And then the third is the clinical quality measure, so the use of CERT to submit those CQMs and other such measures selected by the Secretary. Meaningful use health outcome priorities. So the priorities of the Meaningful Use program is to improve quality, safety, efficiency, and reduce health disparities. It's also to engage patients and families in their health care. Another priority is to improve care coordination, improve the population and public health, and least but not most, ensure adequate privacy and security protections for personal health information. So we're going to go over an overview of all the requirements of the program. So first, all eligible professionals, otherwise known as EPs, are required to attest to Stage 3 for meaningful use for Program Year 2020. All EPs must have the 2015 Edition CEHRT implemented. There are 8 objectives, and their related measures must be met. 5 objectives are percentage-based measures, and 3 of those objectives are yes-no measures. If exclusions are selected for those objectives or measures, the EP must meet the exclusion criteria. The EPs must report on minimum required number and type of eCQMs, must maintain at least 80% of all unique patients' data in CERT, and must perform at least 50% of all encounters at locations with CERT. In addition to meeting the MU requirements listed above, the EP must meet all eligibility requirements of the program. To learn more about those eligibility requirements, you can use the link on this slide. And keep in mind that CEHRT and Access will be making these slide decks available to you after the webinar. To access the webinars, you'll click on the link above, then click the drop-down arrow on the website labeled Educational Resources. Keep in mind that an updated documentation retention webinar for Program Year 2020 is planned for November 5th, 2020. So if you're interested in that webinar, please sign up and put that on your calendars. Program Year 2020 Meaningful Use Reporting Period links. So these are the different reporting periods that will be used by the EPs attesting to the program. The PI reporting period is 90 days for all EPs, and that reporting period must be within calendar year 2020. So for the eCQM reporting period, it's a little different and can vary depending on the EP. The eCQM reporting period is 90 days for all EPs, and that reporting period does not have to meet the PI reporting period, otherwise known as the Meaningful Use reporting period, that covers the percentage-based and yes-no measures. However, the eCQM reporting period must be within calendar year 2020. Let's discuss the 2015 Edition CEHRT requirement. So all EPs must use the 2015 Edition CEHRT for Program Year 2020. that 2015 Edition CEHRT did not have to be implemented on January 1st of the year. The CEHRT must be implemented by the first day of the PI reporting period. And the CEHRT must be certified by ONC as a 2015 Edition product by the last day of the PI reporting period. So for example, the 2015 Edition may have been implemented by the practice before the start of the PI reporting period, even though the product is still pending ONC certification. However, that certification must be approved by the last day of the reporting period. You can see the ONC website, and that's a link right there on the slide, to learn when various CEHRT products were certified to ensure that the CEHRT that you are using is actually certified. So documentation to support that the practice has a 2015 Edition CEHRT, so the EP must use that CEHRT for program year 2020. The CEHRT documentation should include the date the 2015 Edition CEHRT was implemented, the edition number, and the practice name. So some examples of that documentation could be a CEHRT contract, a vendor letter, and it could be a variety of other documents, but you want to make sure it has those 3 requirements listed on the documentation you submit. So general requirements. An EP must maintain at least 80% of all unique patient data at locations with CEHRT in the CEHRT. And the EP must also perform at least 50% of all encounters at locations with CEHRT. EPs who practice in multiple locations must have 50% or more of their patient encounters during the PI reporting period at a location or locations equipped with CEHRT. So documentation to support the general requirements. The EP must submit a detailed encounter listing for the reported 90-day PI reporting period in Excel containing the following fields: the patient name or unique identifier for the patient, the date of service, the date of birth, the location name for where that patient was seen, and then identify which patients do not have data maintained in the CEHRT if they were seen at a location that has CEHRT. So there's 50 patients that are seen at a practice and 2 of the patients are not kept in CEHRT, like their data is not kept there, you need to identify that in the Excel document. So just a few definitions of documentation terms that we will be using throughout this presentation. So EPs are required to upload documentation for each measure. The following slides describe the documentation required for each measure. The standard documentation that we will refer to multiple times. So there are 2 types of standard documentation depending on the measure. There's the yes-no standard documentation, which applies to the 3 measures that are yes-no. And then there's the remaining 5 measures that are percentage-based. We're going to refer to their documentation as the percentage-based standard documentation. When we talk about additional documentation, it's when the EP must submit standard documentation and the additional documentation listed. When we talk about alternate documentation, it's talking about how the EP has the option to submit alternate documentation in lieu of the standard documentation. So stage 3 objectives. Here's just an overview of all the measures that fall underneath each of the 8 objectives. As you can see, there are 8 objectives for stage 3. In the second column, it talks about the objective name. In the third column, it talks about the type of measure. Is it yes, no, or is it percentage-based? In the next column, it talks about the type of documentation that may be required. So right on that first row, you'll see it says for the first objective, protect patient health information, it says to see the SRA webinar. The SRA webinar link is to the right in the last column underneath resources. So for each of these objectives, it kind of breaks it down to where you can go into each of these different webinars that have previously been provided, and you can look into what those webinars, what the specific type of documents are for each of these objectives, if you have any confusion with any of these objectives and what type of documentation may be required. Keep in mind that for different objectives, additional documentation may be needed if the exclusion is claimed. So for more detailed information, you're going to use that last right column to walk through each of the webinars for those specific objectives. And then keep in mind for objective 8, which is the public health reporting, an updated public health reporting webinar for program year 2020 is planned for September 17th, 2020. So if you want to attend that webinar, please make sure to sign up so that you're ready to go and it's a reminder on your calendar. The standard documentation when it comes to percentage-based measures. So unless otherwise specified, you want to submit the CEHRT dashboard for all percentage-based measures. The CEHRT dashboard should include the following 4 items. It should reflect the correct PI reporting period. It should include the provider's name. It should reflect all percentage-based measures, and it should match the attestation to what you attested to. If attesting to an exclusion for a measure, the CEHRT dashboard may be utilized to support meeting the exclusion criteria for certain measures. If the exclusion is not supported by the CEHRT dashboard, additional documentation is required. So when it comes to yes-no measures, documentation must still be submitted for the yes-no measures. The CEHRT dashboard alone cannot be used to support those measures, and the documentation should include the following. It can be screenshots from the CEHRT or vendor letters to support the applicable functionalities were enabled or the actions required were performed. Whether it's screenshots or vendor letters, the documentation submitted should include the following 4 items. It should include the provider and or practice name, depending on what is applicable. It should reflect results for the measure. It should be clearly legible, and it should reflect the date the requirement was met. Now let's discuss what specific dates are required and is sufficient. So when it comes to the security risk analysis, which is objective 1, the SRA must be completed on or after the end of the PI reporting period and no later than December 31st, 2020. When it comes to the clinical decision support rule and drug and drug allergy interaction checks, the documentation should reflect the date the requirement was met during the PI reporting period. For public health measures, the documentation should reflect the date within 60 days of the start of the PI reporting period. Providers that completed registration in a previous year meet active engagement option 1. Keep in mind that documentation should reflect the date the requirements were met. So for example, submitting a screenshot, you want to capture the date the screenshot was taken. So the toolbar at the bottom, so when you're taking that screenshot, make sure you screenshot everything that's needed plus the date that screenshot was taken. So stage 3, compliance summary. So here's just another slide that just gives you a general idea of the different objectives, which objectives have to be met. As you can see, it outlines each of the 8 objectives. In the 3rd column, it talks about compliance. So it says all EPs going all the way down. So it's telling you that each EP that attests must meet every single one of these objectives. In the next column, which is the EP state exceptions, it tells you if the state of Arizona has a specific exception for an EP. As you can see towards the bottom, Objective 8, Registry Reporting, there are certain exceptions for Arizona EPs. So for example, 4 rows up from the very bottom, it talks about syndromic surveillance reporting. So all EPs should be meeting Objective 8. However, there is an exception for Arizona EPs. They are able to take an exclusion in the state of Arizona. We will discuss this exception in further detail later on. As you can see in the second to last column, it talks about the exclusions. Are there exclusions available that CMS allows for each of the objectives? And then in the last column, it talks about how many measures there are. As you can see for Objective 2, electronic prescribing, in the far right column, it explains that there's Measure 1 and Measure 2. Now moving down to Objective 8, Registry Reporting. For immunization registry reporting, keep in mind that it does require that an EP is able to bidirectionally exchange data. That is a requirement for stage 3. And then you'll see there's some syndromic surveillance reporting underneath Objective 8, electronic case reporting. There's public health registry reporting. And as you can see, there is a cancer registry in the state of Arizona, which accepts EP specialties, and they're listed out, those specific specialties that the cancer registry accepts data from. So stage 3 exclusions. There are 8 objectives, as you can see, and it lists out the different exclusions going across. So for the first objective, which is protect patient health information, there are no exclusions available to an EP. Every EP must meet that requirement. For Objective 2, electronic prescribing, an EP has 2 possible exclusions. If the EP has less than 100 permissible prescriptions, they can meet the exclusion. Or if the EP doesn't have any pharmacies within 10 miles of the practice. For Objective 3, clinical decision support, there is only 1 exclusion possible, and it only meets for Measure 2. So Measure 1 has no exclusions underneath that objective, but Measure 2, if an EP has less than 100 medication orders during the PI reporting period. And this is just a general overview. We will discuss these in further detail in the following slides coming up. So stage 3 CQM requirements. EPs must attest to 6 out of 47 available CQMs. 6 of those CQMs are outcome measures, 27 are high priority measures, and 14 are just remaining measures. So the first priority that an EP needs to try to meet, if relevant, they need to have at least one CQM that is an outcome measure. However, if that is not relevant to the provider's specialty or the types of patients that they see, they should move on to priority level 2 and try to meet that, which is if no outcome measure is relevant, at least one CQM should be a high priority measure. And there are 27 high priority measures that EP can pick from. If they're not able to meet priority level 2, they would move down to priority level 3 and try to meet that. If no outcome or high priority measures are relevant, report on relevant measures if possible. There's a link at the bottom that discusses the clinical quality measures webinar. So if you want more details, like the type of documents that should be submitted, you can go to that webinar and do further research. So what type of documentation is required for CQM? The provider should run a CQM report from the CEHRT for the appropriate reporting period. They should prove the CQM data was calculated by 2015 Edition CEHRT. Some examples to prove that is the report must show the CEHRT name, or it can be screenshots demonstrating how the report was pulled from the CEHRT. The report should include the following: the required number and type of CQM, the numerator and denominator for each CQM, the most recent CQM version the CEHRT has available, and it should reflect the proper reporting period. Here's just a general broad slide explaining the changes from program year 2019 to program year 2020. As you can see, the first change that occurred was Objective 5, Measure 1, Patient Electronic Access. In program year 2019, the API for that measure could be enabled before, during, or after the PI reporting period, as long as it was enabled by December 31st, 2019. However, that changed for program year 2020. CMS is requiring that the AP must be enabled within 48 hours of the information being available to the EP for each patient that timely access to their health information via the API is an option for the patient. The second thing to change, it was the CQM reporting period. In 2019, the CQM reporting period in program year 2019 is 865 days for all returning meaningful UCPs. However, in program year 2020, the CQM reporting period in program year 2020 is 90 days for all EPs. The third item to change for CQM was the EPs may select 6 CQMs out of 50 available CQMs. However, in 2020, the EPs may select 6 CQMs out of only 47 CQMs, so that the number of total CQMs did decrease slightly. There were no other changes between program year 2019 and program year 2020 other than the 3 listed on this slide. So in the objective details, let's go by each objective and move down the list. So objective 1, protect patient health information. The objective is to protect electronic protected health information created or maintained by the CEHRT through the implementation of appropriate technical, administrative, and physical safeguards. The measure is to conduct or review a security risk analysis in accordance with the requirements under 45 CFR, including addressing the security, which includes encryption of data created or maintained by the CEHRT. They also need to implement security updates as necessary and correct identified security deficiencies as part of the provider's risk management process. As you can see, there are no exclusions available for this measure. A security risk analysis should contain a layered approach and be dated appropriately. Although there is no specified method that guarantees compliance, there are several elements a risk analysis must incorporate regardless of the method employed. They must contain the asset inventory. They must contain physical, administrative, and technical safeguards, including encryption to EPHI, must identify threats and vulnerabilities. They must determine the likelihood of threat occurrence. It must determine the potential impact of threat occurrence. It must determine the level of risk and the remediation/action plan. There's a link at the bottom if you want to research this objective further. And so there is a security risk analysis webinar that goes into more detail. So let's talk about the date of the SRA. It must be completed on or after the end of the PI reporting period and no later than December 31st, 2020, and must show the date completed. Here, there are some examples we're going to walk through in this table. They're all for program year 2020. The first example talks about the provider's PI reporting period was January 1st to March 31st, 2020. So when must that EP complete the annual SRA and date it? That must be between March 31st, because that was the last day of the PI reporting period. They can complete the SRA any time between March 31st and December 31st, because December 31st is the last day of the program year. The second example is for an EP who has a PI reporting period October 1st to December 29th. That EP should complete the annual SRA between December 29th, the last day of the PI reporting period, or December 31st, the last day of the calendar year. So they have 3 days to finish reviewing that SRA and dating it. If that SRA is dated for December 28th for that EP, for that second example, it would not be sufficient. The third example is an EP who has a PI reporting period June 1st through August 29th. That EP has the option to complete the SRA between a couple months span, August 29th through December 31st. The last example is an EP whose PI reporting period is October 3rd through December 31st. The only date that they can finalize that SRA is December 31st of 2020. It cannot be December 30th of 2020 or January 1st of 2021. It must be December 31st, 2020. Keep in mind that the SRA report must include the completion date, including the month, the date, and the year. All three of those things need to be on the SRA. Objective 2, electronic prescribing. The objective is to generate and transmit permissible prescriptions electronically. The measure is that for more than 60% of all permissible prescriptions written by the EP are queried for a drug formulary and transmitted electronically using a CEHRT. The exclusions. There are two types of exclusions for this measure. Keep in mind that an EP is not required to submit data or meet the measure if they take the exclusion. However, the EP must submit documentation of how he or she meets that exclusion. And those two exclusions are the number of permissible prescriptions criteria and the pharmacy proximity criteria. So for those two exclusions, let's look in detail at the requirements. The first exclusion is if the EP writes fewer than 100 permissible prescriptions during the PI reporting period. The second exclusion is if the EP does not have a pharmacy within their organization and there are no pharmacies that accept electronic prescriptions within 10 miles of the EP's practice location at the start of his or her PI reporting period. The documentation requirements for this objective is the percentage-based standard documentation, so you can see slide 14 for details regarding that. There are also examples of supporting documentation to meet this measure included in the link below, which is the documentation retention webinar. Keep in mind that webinar will be redone and presented to the providers in Arizona on November 5th, 2020. So let's look at the exclusion documentation requirements. So if the EP writes fewer than 100 permissible prescriptions, there are two types of documents that can be submitted. The standard documentation, which is the CEHRT dashboard showing that the EP wrote fewer than 100 permissible prescriptions during the PI reporting period. The second type is the alternate documentation, which is providing supporting documentation other than the CEHRT dashboard that demonstrates the EP has fewer than 100 permissible prescriptions. Moving on to that second exclusion, which is no pharmacy within the organization or within 10 miles of the EP's practice. The EP will need some additional documentation, which is showing the closest pharmacy to the practice at the start of the PI reporting period. And they must demonstrate how they determine no pharmacy is within 10 miles of the practice. For additional information, you can see the electronic prescribing webinar, which will be presented and on the Access website. Moving on to Objective 3, clinical decision support. The objective is to implement clinical decision support, otherwise known as CDS interventions, focused on improving performance on high priority health conditions. Measure 1 is to implement 5 CDS interventions related to 4 or more CQMs at a relevant point in patient care for the entire PI reporting period. Absent 4 CQMs related to an EP scope of practice or patient population, the CDS interventions must be related to high priority health conditions. Measure 2, enable and implement the functionality for drug-drug and drug-allergy interaction checks for the entire PI reporting period. So if the EP does claim an exclusion, they are not required to submit data or meet the measure. However, they must submit documentation of how they met the exclusion. The only exclusion for Objective 3, Measure 2, is the number of medication orders criteria. As you can see for Measure 1, there are no exclusions available. For Measure 2, an EP may take an exclusion if the EP writes fewer than 100 medication orders during the PI reporting period. So let's discuss the documentation requirements for this objective. As you can see, there are links at the very bottom for the CDS webinar if you want more details beyond what we're about to discuss. For the measure documentation, the EP needs to submit yes/no standard documentation for both measures, and you can see slide 15 of this presentation to see the requirements of what we look for on that yes/no standard documentation. Examples of supporting documentation to meet this measure are included in the link below, which is that CDS webinar. When it comes to exclusion documentation, it only applies to Measure 2. Measure 1 has no exclusions available. And that exclusion for Measure 2 is writing fewer than 100 permissible prescriptions. There are 2 types of documentation that can be submitted to support the exclusion. The first one is the standard documentation. It's the CERT dashboard showing that the EP wrote fewer than 100 medication orders during the PI reporting period. The other option for the EP is to submit alternate documentation, which is the provider supporting documentation other than the CERT dashboard that demonstrates the EP has fewer than 100 medication orders. Objective 4, computerized provider order entry. The objective is to use CPOE for medication, laboratory, and diagnostic imaging orders directly entered by any licensed healthcare professional, credentialed medical assistant, or medical staff member credentialed to and performing the equivalent duties of a credentialed medical assistant who can enter orders into the medical record per state, local, and professional guidelines. There are 3 measures. An EP, through a combination of meeting the thresholds and exclusions, or both, must satisfy all 3 measures for this objective. Measure 1 is more than 60% medication orders created by the EP during the reporting period are recorded using CPOE. Measure 2 is more than 60% of laboratory orders created by the EP during the reporting period are recorded using the CPOE. For Measure 3, more than 60% of diagnostic imaging orders created by the EP during the PI reporting period are recorded using the CPOE. There are exclusions available, and if the EP does claim an exclusion, the EP is not required to submit data to meet the measure. However, the EP must submit documentation about how he or she met the exclusion. There are 3 exclusions for Objective 4. Number of medication orders criteria, number of laboratory orders criteria, and number of diagnostic imaging orders criteria. An EP may take an exclusion for the appropriate measure if, for Measure 1, an EP writes fewer than 100 medication orders during the PI reporting period. An EP can take an exclusion for Measure 2 if the EP writes fewer than 100 laboratory orders during the PI reporting period. And an EP can take an exclusion for Measure 3 if the EP writes fewer than 100 diagnostic imaging orders during the PI reporting period. The documentation for CPOE. The EP should submit the percentage-based standard documentation, which is on slide 14 of this presentation. Examples of supporting documentation to meet this measure are included in the link below, which is the documentation retention webinar. Moving on to exclusion documentation. If the EP writes fewer than 100 orders for the applicable measure, there are 2 types of documentation that can be submitted by the EP to support that exclusion. The first one is the standard documentation. It is the CERT dashboard showing that the EP wrote fewer than 100 orders for the applicable measure during the PI reporting period. The second type of documentation is the alternate documentation, which is when EP provides supporting documentation other than the CEHRT dashboard that demonstrates the EP has fewer than 100 orders for the applicable measure. As you can see, there's additional information in the CPOE webinar that goes into more detail. Moving on to Objective 5, Patient Electronic Access. There are two measures for this objective, and EP must satisfy both measures for this objective through a combination of meeting the thresholds and exclusions discussed on the following slides. For Measure 1, it is more than 80% of all unique patients seen by the EP must have the following two things. The patient or the patient authorized representative is provided timely access to view online, download, and transmit his or her health information. Keep in mind that per CMS, timely access means the information is provided to the patient within 48 hours of the information being available to the EP. So that's that first requirement under Measure 1 for more than 80% of all unique patients seen by the EP. The second requirement is the provider ensures that PHI is available for the patient to access using any application of their choice that is configured to meet the technical specifications of the Application Programming Interface, otherwise known as API, in the provider's CEHRT. Measure 2, an EP must use clinically relevant information from the CEHRT to identify patient-specific educational resources and provide electronic access to those materials to more than 35% of unique patients seen by the EP during the PI reporting period. If the EP claims the exclusion, the EP is not required to submit data or meet the measure. However, the EP must submit documentation of how he or she met the exclusion. There are two types of exclusions for Objective 5, Patient Electronic Access. The first one is no office visits criteria, and the second one is the broadband criteria. So for those exclusions, Measures 1 and 2, an EP may take an exclusion for either measure or both if either of the following apply. The first exclusion is the EP has no office visits during the PI reporting period. That exclusion applies to Measures 1 and 2. The second exclusion is the EP conducts 50% or more of his or her patient encounters in a county that does not have 50% or more of its housing units with 4 megabytes per second broadband availability, according to the latest information available from the Federal Communications Commission on the first day of the PI reporting period. For the broadband access exclusion, for program years 2015 through 2017, CMS identified the counties in the U.S. who conducted 50% or more patient encounters in a county where 50% or more of its housing units do not have 4 megabytes per second broadband availability and therefore meet the broadband exclusion. The state of Arizona does not have any counties listed. Therefore, an EP in Arizona is not able to meet this exclusion for program year 2020. Please keep that in mind as you move when you go to a test and when you're looking at your documentation. An EP in the state of Arizona is not able to claim the broadband access exclusion. There's more details in the link at the bottom showing you that CMS tip sheet for which counties meet that requirement. The documentation for patient electronic access. An EP must submit the percentage-based standard documentation, so see slide 14 in regards to the requirements of what that documentation needs to contain. And additional documentation will be required for this objective. To determine the documentation necessary to support meeting this measure, you'll click the link below, which takes you to the Program Year 2020 Patient Electronic Access webinar. If you have any questions after looking to that webinar, please feel free to reach out to Access or Health Current with those questions. For exclusion documentation, if the EP is claiming to have no office visits during the PI reporting period, the EP must submit additional documentation, and that's to show the place of service code for all encounters during the PI reporting period. For the broadband access exclusion, keep in mind that Arizona EPs are unable to meet this exclusion per CMS. Moving on to Objective 6, Coordination of Care. The first measure, it's more than 5% of all unique patients seen by the EP actively engage with the EHR and made accessible by the EP, and either one, they view, download, or transmit to a third party their health information, or 2, they access their health information through the use of an API that can be used by applications chosen by the patient and configured to the API in the EP CEHRT. Or they can go with the third option, which is a combination of 1 and 2. Measure 2 is for more than 5% of all unique patients seen by the EP during the PI reporting period. A secure message was sent using the electronic messaging function of CEHRT to the patient or in response to a secure message sent by the patient or their authorized representative. For Measure 3, patient-generated health data or data from a non-clinical setting is incorporated into the CEHRT for more than 5% of all unique patients seen by the EP during the PI reporting period. An EP must meet the minimum threshold for 2 of the 3 measures or meet 1 of the 2 available exclusions. The exclusions for all 3 measures are the same. If the EP meets 1 of the exclusions, they can meet the exclusion for all 3 measures. Some examples of possible combinations are included below. For the first example, it shows the EP is passing because the EP under Measure 1 meets the threshold, under Measure 2, they meet the threshold, and under Measure 3, they do not meet the threshold. But they still met 2 of the 3 thresholds for the 3 measures, so they're passing. For the second example, it shows the EP is passing because they met 1 threshold for Measure 1, and then they met the exclusions for 2 and 3. The third example also shows the EP is passing because they took an exclusion for all 3 measures. The last example is a failing example, and it shows that the EP does not meet the threshold or the exclusions for measures 1, 2, or 3. So if the EP claims an exclusion, the EP is not required to submit data or meet the measure, but the EP must submit documentation about how he or she met the exclusion. The exclusions for Objective 6, coordination of care, is the office visit criteria and the broadband criteria. We discussed this during Objective 5, which is when the exclusions are the same. The EP has no office visits during the PI reporting period, or the EP meets that broadband availability as defined with the requirements from CMS. The documentation requirements for coordination of care. So when the EP is meeting those measures, they must submit percentage-based standard documentation and see slide 14 of this presentation for the details that we look at. There is additional documentation required if attesting to meeting Measure 3, an explanation of what patient-generated health data is being utilized and how the CEHRT is capturing that data. Some examples of supporting documentation to meet this measure are included in the link below, which is the documentation retention webinar. For the exclusion documentation, as previously discussed, when an EP has no office visits during the reporting period, they must submit that additional documentation. Moving on to the second exclusion for broadband access, an Arizona EP is not able to meet the exclusion per CMS, and the links are there for the CMS broadband tip sheet. Also at the bottom of the slide, you can see that for additional information, you can look at the coordination of care webinar. Moving on to Objective 7, Health Information Exchange. This just discusses the objective generally. The EP provides a summary of care record when transitioning or referring their patient to another setting of care, receives or retrieves a summary of care record upon the receipt of a transition or referral, or upon the first patient encounter with a new patient, and incorporates summary of care information from other providers into their EHR using the functions of a CEHRT. Measure 1, for more than 50% of transitions of care and referrals, the EP that transitions or refers their patient to another setting of care or provider of care, 1, creates a summary of care record using CEHRT, and 2, electronically exchanges the summary of care record. Measure 2, for more than 40% of transitions or referrals received in patient encounters in which the EP has never before encountered the patient, he or she incorporates into the patient's EHR an electronic summary of care document. Measure 3, for more than 80% of transitions or referrals received in patient encounters in which the EP has never before encountered the patient, he or she performs a clinical information reconciliation. The EP must implement clinical information reconciliation for the following 3 clinical information sets. 1, medication, so review of the patient's medication, including the name, dosage, frequency, and route of each medication. For 2, they review the patient's known medication allergies. And for 3, they review the patient's current and active diagnoses. An EP must meet the minimum threshold for 2 of the 3 measures. This is very similar to the last objective, Objective 6, coordination of care. If the EP meets the criteria for exclusion from 2 measures, they must meet the threshold for 1 of the remaining measures. If they meet the criteria for exclusion from all 3 measures, they may be excluded from meeting this objective. There are some examples of possible combinations included below. I'll leave that for y'all to read when these slides are sent out to you. If you have any additional questions about those examples, feel free to reach out to Health Current or Access, and we can respond to those questions. Again, if an EP claims an exclusion, they are not required to submit data to meet the measure, but they must submit documentation of how he or she met the exclusions. There are 3 possible exclusions for Objective 7, the number of patient transfers criteria when the EP is the sender, the broadband criteria, and the 3rd exclusion is the number of patient transitions and referrals criteria when the EP is the receiver. An EP may take an exclusion if the EP meets the exclusion criteria applicable to the measure in the table below. As you can see in that first column, it talks about for measure 1, and then the second column, it tells you what that exclusion is on that first row. So an EP transfers a patient to another setting or refers a patient to another provider fewer than 100 times during the PI reporting period. That exclusion is only for measure 1. However, moving down to the next row, measures 1 and 2, the exclusion is the broadband criteria. So if the EP met the broadband criteria, they could take that exclusion for measures 1 and 2. However, in Arizona, the EP is not able to claim the broadband exclusion. Moving down to that last exclusion, it applies to measures 2 and 3. The total transitions or referrals received and patient encounters in which the EP has never before encountered the patient is fewer than 100 during the PI reporting period. Documentation for this objective is the EP must submit the percentage-based standard documentation. In detail, it shows the requirements on slide 14. Examples of supporting documentation to meet this measure are included in the documentation retention webinar link. The exclusion documentation, so if an EP transfers a patient to another setting or refers a patient to another provider fewer than 100 times, which that's only for measure 1, you need to provide documentation supporting that. The second exclusion, moving on, is the total transitions or referrals received in patient encounters in which EP has never before encountered the patient is fewer than 100. So this applies to measures 2 and 3. So the next 2 bullet points, the standard documentation and the alternate documentation, you can provide either of those documentation to meet the 2 exclusions discussed above. The standard documentation is providing the CEHRT dashboard showing that the EP had fewer than 100 qualifying transitions, referrals, encounters for the appropriate measure during the PI reporting period. Or instead of that, the EP can provide alternate documentation, which is providing supporting documentation other than the CEHRT dashboard that demonstrates the EP had fewer than 100 transitions, referrals, or encounters for the appropriate measure. Moving on to broadband access exclusion, that applies to measures 1 and 2. However, Arizona EPs are unable to meet the exclusion per CMS. For additional information, see the Health Information Exchange webinar. If you have any questions, again, please reach out to Health Current or Access. Moving on to Objective 8, Public Health Reporting. The objective is for the EP to be in active engagement with a public health agency or clinical data registry to submit electronic public health data in a meaningful way using CEHRT, except where prohibited and in accordance with applicable law and practice. An EP must satisfy 2 of the 5 available measures for this objective. If the EP cannot satisfy at least 2 measures, they may still meet the objective if they qualify for exclusion from all measures they cannot meet. Measure 1 is the immunization registry reporting. The EP is in active engagement with a public health agency to submit immunization data and receive immunization forecasts and histories from the public health immunization registry. Keep in mind, EPs must exchange data bidirectionally to meet this measure. For Measure 2, syndromic surveillance reporting, the EP is in active engagement with a public health agency to submit syndromic surveillance data. Measure 3 is electronic case reporting. The EP is in active engagement with a public health agency to submit case reporting of reportable conditions. Measure 4, public health registry reporting. The EP is in active engagement with a public health agency to submit data to public health registries. Measure 5, clinical data registry reporting. The EP is in active engagement to submit data to a CDR. Here's a general overview of the available registries in Arizona. So for the first measure, which is immunization, Arizona has an Arizona State Immunization Information System. There's no second available registry in Arizona. For syndromic surveillance, which is the second measure, it is not available to EPs in the state of Arizona. For Measure 3, the electronic case reporting is not available to EPs or EHs. For Measure 4, public health registry reporting, keep in mind that EPs may choose to report up to 2 registries and count each public health registry towards the 2 measures required by the objective. In Arizona, the first available registry is the cancer registry, and it is available to EPs who diagnose and treat more than 100 cancer cases per year. The second available registry is to research a national public health registry related to your specialty. The fifth measure, which is the clinical data registry reporting, again, an EP can choose to report on up to 2 registries and count each registry towards the 2 measures required by the objective. There are 2 different links here explaining, so once you go to that link, you can see the approved clinical data registries for 2020 that an EP can potentially submit to. So check out that website to see what potential registries you could use, and you can choose up to 2 registries to report to and use as your 2 measures. Again, for exclusion, if you claim an exclusion, you need to submit documentation of how you met that exclusion. There are 5 different exclusions for Objective 8 public health and clinical data registry reporting. The first one is if the EP does not administer to the population. The second one is they do not diagnose or directly treat reportable diseases collected by the registry. The third is the registry is not capable of accepting in the jurisdiction. The fourth is data is not collected in the jurisdiction the EP is in. And the fifth is registry has not declared readiness. So an exclusion for a measure does not count towards the total of 2 measures. In order to meet this objective, an EP needs to meet 2 of the total number of measures available to them. If the EP qualifies for multiple exclusions and the remaining number of available measures is less than 2, the EP can meet the objective by meeting all the remaining available measures and claiming the applicable exclusions. Available measures are ones for which EPs do not qualify for an exclusion. The EPs do not operate or is not required to operate or operates in a jurisdiction where the applicable data is not collected by that jurisdiction's registry. Specifically, Measure 1 does not administer immunizations to any of the populations for which data is collected. Measure 2 are not in a category of providers from which ambulatory syndromic surveillance data is collected. And it goes on through Measure 3 where they do not diagnose or directly treat any reportable diseases for which data is collected, and so on and so forth for the remaining measures. For Exclusion 2, which is the appropriate exclusion can be claimed if at the start of the PI reporting period, the EP practices in a jurisdiction for which, Measure 1, no immunization registry is capable of accepting the specific standards required to meet the CEHRT definition. And then it just applies that same exclusion to the remaining measures, Measure 2, syndromic surveillance, Measure 3, case reporting, and so on and so forth. Please note that the definition of jurisdiction is general, and the scope may be at the local, state, regional, or national level. For Exclusion 3, it uses the same general idea. It is the appropriate exclusion can be claimed if 6 months prior to the reporting period, the EP practices in a jurisdiction where that applicable registry has not declared readiness. So no immunization registry has declared readiness to receive immunization data. Moving down to Measure 5, no clinical data registry for which EP is eligible to submit data has declared readiness to receive electronic registry transactions. So again, that exclusion is very similar for all 5 measures, but you just have to apply that exclusion depending on what type of registry it is. So let's talk about the documentation. What do you need to submit to meet these measures? The measure documentation is yes, no standard documentation for each measure, and so you can look at slide 15 to see the specific details of what needs to be on each document. Examples of supporting documentation to meet this measure are included in the link below, which is the Public Health Reporting webinar. The exclusion documentation, you can submit additional documentation for Exclusion 1, which is explain and document why the EP does not or is not required to collect data for the applicable measure in their jurisdiction. The second is additional documentation for Exclusions 2 and 3. An EP must complete 2 actions in order to find available registries or claim exclusion. First, they must determine whether his or her jurisdiction endorses or sponsors a registry, and second, determine whether a national specialty society or other specialty society with which he or she is affiliated endorses or sponsors a registry. Just keep in mind, I know this is a lot of information, but in addition to meeting those MU requirements discussed throughout this presentation, the EP must meet all eligibility requirements of the program, including the minimum Medicaid and/or needy patient volume. To learn about those eligibility requirements, you can use the following link, which is the documentation retention webinar. And if you have additional questions as you're going through all of that, again, please feel free to reach out to Health Current or Access, and we can answer those questions for you. So just to briefly discuss some audit findings. So what happens during an audit? All providers that receive a Medicaid PI incentive payment could potentially be selected by Access for post-payment audit. If selected, an analyst will conduct a thorough review of the documentation attached to the EP's attestation EPIP to determine if it meets the program requirements, and Access may have follow-up questions or make additional documentation requests. Some common audit findings: failure of the EP to provide sufficient documentation for protecting electronic health information. The CEHRT dashboard does not show the reporting period or the EP name. The EP's failure to maintain proper documentation. Another common audit finding is supporting documentation does not have the appropriate date, so make sure you have the appropriate date depending on the measure. And the last common audit finding is including data for the entire practice in the reported CEHRT report rather than data for the individual EP. Keep in mind, these examples do not cover all of the audit findings that have been discovered throughout the years, so just make sure you ensure that the documentation meets all the requirements that we've discussed on the previous slide. Here are some resources that we used throughout our presentation and just shows where CMS has identified each of these requirements. Keep in mind that there is a Program Year 2020 Stage 3 FAQ. So if you do have any questions, you can look there, see if we answered those questions you may have. I know we're nearing the end of our time, so if you do have any questions and want those answered, you can put those in the chat box, or please feel free to reach out to Health Current or Access. We want to help you all as much as possible gathering all these documents for Program Year 2020. And there is contact information on this slide for Access and Health Current. There is an email and a phone number listed if you have any questions at all. I know this is a lot of information for y'all, but again, these slides will be sent out to y'all and made available, as well as here's the contact information if you have any questions at all that are needed. And I'll hand this back over to Health Current. Unless y'all have any other questions, please feel free to put those in the chat box.
Thank you very much, Priscilla. It's a very informative presentation on the Program Year 2020 Stage 3 requirements. Excellent job. Thank you for that. Christine, do we have any questions in the chat box?
We do not at this time, Connie. We can give folks a few extra minutes if they're working on typing those questions in. Again, the chat box is open to ask Priscilla questions about today's presentation.
Thank you, Christine. And just while y'all are typing in those potential questions, there is this Word document that has the FAQs in there. So if you don't know where to start potentially, feel free to open up that frequently asked questions document. We've already provided the answers to those questions that we thought you might have as you're preparing for Program Year 2020. So there are a lot of questions in here. If you do have any questions, it just discusses what changed between the program years, as well as a lot more other questions.
Priscilla, there is a question in the chat box. I guess it's not a question, maybe it's a statement. Access will have the 2020 MU checklist for providers.
Thank you, Christine, for pointing that out. Yes, so Access is preparing a program year 2020 MU checklist for the EPs that are testing for that program year to just help you put it all together and know what you need to check off to meet the program requirements. So that should be released to the providers very soon. If you have any questions, please feel free to put those questions in the chat box. Or again, there is the contact information. You can reach out to Access or Health Current to ask any additional questions after in this webinar.
Priscilla, is there another upcoming presentation similar to the one we watched today in case they missed part of the presentation?
So I know we're going to be sending out the PowerPoint slides. We will not be redoing stage 3 for program year 2020. But again, if you do have questions or if you want someone to potentially answer those questions about specific slides, please reach out to Access and let them know that. And I know that they'd be willing to schedule a conference call if needed and to discuss any confusion or any additional questions as you're going through the slides once they're made available. And we do have open forums scheduled throughout the next year. So I advise you to please join those open forums if you have additional questions. Access, Health Current, and Myers and Stauffer will be available during the open forums to answer questions. And I know Health Current has a newsletter that goes out to notify you of any upcoming presentations and open forums. So please join that newsletter to get that information.
Thank you, Priscilla. This session is being recorded and will be posted both on the Access website as well as the Health Current website.
And I believe Health. Go ahead.
Go ahead. Sorry, Priscilla, you go right ahead.
I just saw your comment, Christine, so I wanted to point out to everyone. So if you want to register for future events, there is that website that is put in the chat box, healthcurrent.org/events. So feel free to go to that website, or if something's not working along that way, or if you just missed copying the website before we end this webinar. Again, just a simple question. If you want to reach out and send an email to Access or Health Current, they can help direct you to that event page to sign up for future webinars.
And we will be having a 2020-2021 webinar schedule that will come out in the near future. So we'll be also posting that at healthcurrent.org/events and communicating through our monthly e-newsletters. So look for more of that to come. Priscilla, we are right at the top of the hour, so we will be needing to conclude today's webinar. Again, if you do have questions, folks, for Access, Myers Stofers, or Health Current, the contact information is displayed on the screen. Again, we will send out the slide deck following today's presentation, and we will also post the recording of this both on the Health Current and Access websites. That concludes today's webinar. Thank you, Access. Thank you, Priscilla and Myers and Stauffer for presenting today, and for all of those that are participating. Thank you very much. Enjoy your day.